lecture is on the encoder in general and on going through the steps of using the 3M encoder, specifically to identify how we would use it in PCS coding. For the purposes of health information management, an encoder is a software program that converts data from one format to another and groups ICD diagnoses and if warranted procedure code or codes into an MSDRG. If you remember from your 255 reimbursement class and probably from your HIT 101 class, MSDRG stands for Medicare Severity Diagnosis Related Group. The 3M encoder product also provides information that would be found in the ICD coding manual and also identifies complications and comorbidities as defined by Medicare. There are two basic types of encoders on the market today, a logic-based encoder and a book-based encoder. The logic-based approach has similar search features to a book-based encoder, but it also has built-in logic via questions which prompt the coder to think about other conditions or diagnostic and therapeutic procedures that may have been done during the episode of care. For example, when coding an acute myocardial infarction, there may be a series of questions to pinpoint the site of the infarction as well as determine what procedures were done, such as a cardiac catheterization, whether it was right or left, ventriculography, coronary angiography, PTCA, or even a CABG. If the coder incorrectly answers any of these questions or prompts, it can lead to incorrect code assignment. Or for a new coder, the coder may think that all the procedures must be done for every patient with an acute myocardial infarction. For an experienced coder, many find the process of answering non-applicable questions for the specific case coded to be a tedious and time-consuming process. The electronic codebook type of encoder, which is what we will be using, provides the complete text of the codebooks. The software merely allows access to the appropriate page, which is in electronic format. No prompts are given. There may be pop-ups or edits that alert the coder to other diagnoses or procedures. The user simply browses through the information and selects the appropriate code. Some of these encoders are more sophisticated and include expert coding tips, acronyms in their search engines, ability to customize to organization-specific guidelines, and automated references. That is the type of encoder that the 3M is. It is a book-based encoder. Use of the encoder. To use the encoder in this class, you will have to code the diagnostic portion before you can assign the procedure code and then compute using the 3M software to get the MSDRG. So we will use the following sample case. The patient is a 68-year-old man who has been admitted, and he came in with a complaint of possible gastritis. In general, the patient's health is good outside of and before this abdominal issue. Due to the severity of his pain, he is admitted for further evaluation and treatment. As noted here, he undergoes an endoscopic examination of the lower esophagus and stomach. During this examination, pathurethemias were seen in the stomach and biopsies of the stomach were taken. These specimens were sent to pathology for diagnostic evaluation. The surgeon also noted in the operative report a linear erosion at the gastroesophageal junction. The impression was that the patient had mild reflux esophagitis and mild atrial duodenitis. His dietary care was modified and IV medications were administered. His condition improved and he was discharged in an improved condition to his home with a follow-up with Dr. Fox. So we read the information. We know that the admission diagnosis is gastritis. So we also note the age of the patient. So we move to the encoder. You go through the access steps. You have the male patient. To move forward in the encoder, you must put an age or a birth date. So the patient again was 68 per our clinical documentation. We have his admission and discharge dates. It has to be after 10/1 in order for us to get the correct ICD-10 version, you can enter in the date, or you can use the calendar feature. His date of admission was 10/7, and his date of discharge was 10/10. The length of stay will automatically change. We're going to leave everything alone on this side of the screen. It defaults to DRG Finder, defaults to Medicare, and that's what we want. And then we hit continue. The first thing you land to, you have to put in where the patient went when they left, which is called disposition. Again, it states he was discharged on an improving condition to his home. So we choose 1. You hit the radio button. Now we're going to put in the keyword for the admission diagnosis. Again, if we go back to the clinical documentation, it says that admission diagnosis is gastritis. So we type in that word. Sometimes we only have to type in part of the word to get the 3M to move. So when we type in gastritis, we get 3 options. We choose the one that fits. There's no documentation of bleeding. There's no documentation of any of these other conditions. It doesn't specifically say it's an acute or erosive type, so we would choose unspecified. We get out a code. Note that the code is missing the decimal point. So if you were typing this in the class or typing it somewhere in an assignment, you would have to insert the decimal point. So it would be K29.70 would be the admission diagnosis. This is not the principal. This is the admission diagnosis. 3M requires that you provide an admission diagnosis because, again, ICD coding is about statistics and gathering information. So we then want to move forward. We still want to code the principal diagnosis. Again, we reviewed the clinical information. He came in with abdominal pain. It was noted to be gastritis on admission. They found he had esophagitis and duodenitis. You could really choose either one, but if we choose the first one listed as our principal, he has both of these conditions. Both of these are causing issues. But if we choose the first one in the clinical information, we code that. And again, there's a variety of ways you could get there, but if you put in reflux, you get 3 options: reflex, RSD, and reflux. You choose reflux. Again, it's a gastroesophageal. It does state it was with esophagitis in the clinical documentation. Mild reflux esophagitis, so we choose that option. Does he have a hiatal hernia? No. You could code the procedure at this juncture. I particularly like to code all the diagnoses first, then the procedure. So if you want to do it that way, you would hit no procedure. And again, you get the ICD-CM diagnosis code without the decimal point, so you have to insert it. So the ICD diagnosis code would be K21.0. We have another condition to code, so we still have to code the duodenitis. If you hit continue, you will get there. If you hit add diagnosis, it'll take you back to this screen where you're going to type in part of the word or all of the word. The option that we want is 1. There's no documentation of any bleeding or any of these other conditions, so we hit other or unspecified. There's no documentation the patient had a hiatal hernia. But there is documentation the patient had a procedure. It says that the patient had a endoscopic examination of the lower esophagus and the stomach, and they found certain things. They did a biopsy. These specimens were sent for diagnostic evaluation. So we need to code this procedure. It was done in an inpatient setting. What was being done? What type of procedure was that? It is what is called an EGD. It's an endoscopic view of the esophagus and the top of the stomach. It's via the mouth. So we choose A for EGD, esophageal gastroduodenoscopy. Then we're going to choose biopsy because, again, the patient had biopsies. It's noted in the clinical information. It was noted to be the stomach. We hit stomach, and then we have to hit continue to get the right character. We don't have any more procedures to code. And we get out our ICD-10 PCS code of 0DB68ZX. So per the clinical documentation, we have fully coded this chart. Now we want to get the DRG, the MS-DRG. So we hit continue. It gives us a summary of all our ICD and ICD-10 CM and ICD-10 PCS codes. They're listed in the order that we put them in. If we wanted to change the order, we could right click and we could move a code. You could delete a code. You can edit the text. You can do all kinds of things with the right click, but we don't need to do that in this case. But then we hit the word compute. We get a edit, just telling us that the code, procedure code may not match, but it does match for our clinical information. So we still have our ICD codes. We have our ICD diagnosis codes, and we have our ICD PCS code here at the end. And at the very top here, we have our DRG. This is our DRG, 392. Only that. That's only the DRG. That's the only one thing we ask. If someone asks you, or I ask you what the MS-DRG is for this patient, the answer will be 392. The CMS weight, in this case, for this particular DRG is 0.7400, and the average length of stay is 3.3 days. And all of that information is what we would use to calculate and get reimbursement for this particular patient. And this is how we use the encoder in medical coding to fully assign ICD-10 CM and ICD-10 PCS codes to an inpatient case and then get or compute using the software the MS-DRG. Getting the MS-DRG is important for reimbursement, especially for patients on Medicare or Medicaid. If the patient is on Medicare or Medicaid, the hospital must report the MS-DRG to CMS when submitting the electronic or paper claim for hospital service. Remember that ICD-10 PCS code assignment is only for inpatient admissions, and ICD-10 PCS codes are only assigned per UHDDS guidelines for what constitutes a significant procedure. More about that in HIT 205. But at this time, we are focused on coding surgical events that occur in the operating room, which makes the procedure significant under UHDDS guidelines. The benefit of using an encoder is twofold. It provides computing or grouping of the MS-DRG and gives that information to the hospital as required for reporting to CMS and perhaps other insurance carriers. The encoder also can be integrated with hospital billing software so that once the chart is coded in the HIM department, that information is electronically and automatically sent to the billing department for any needed internal processes before sending the bill electronically to the patient's insurance company. Other applications or benefits of using an encoder are discussed in HIT 205 and other courses in this curriculum. Our focus at this point is for you to have some practice on using the 3M encoder software. There will be general questions on the quiz in this lesson. There will be a practice assignment in Lesson 12 and Lesson 14. Use of the 3M encoder will be required to complete upcoming assignments in this course, starting with one in Lesson 14. Therefore, it is important when noted in Lesson 12 to take some time to practice using the 3M encoder. If you have any questions on this presentation or the basic use of the encoder as I have reviewed it in this presentation, please let me know.